Hi there, my name is Vincent, and I did my systematic review on early mobilization versus delayed mobilization in postoperative CABG patients. A little bit about background. A coronary artery bypass grafting is a revascularization technique that replaces stenosed, sclerosed, or diseased coronary arteries with a graft that allows adequate oxygen perfusion to myocardial tissues. Because it is an invasive and open procedure, it comes with complications such as systemic inflammatory response, acute kidney injury, low cardiac output syndromes, thrombotic events, infection, impaired glycemic control, impaired wound healing, and those associated with ECMO, as well as those associated with ventilation. Early mobilization may be defined as the early application of physical therapy within the first 0 to 5 days in the postoperative period, depending on the author. My PICO question is, in critical postoperative CABG patients, how does early ambulation compared to delayed physical therapeutic intervention affect the rate of mortality within the first 3 months? The reason I chose this topic was because I was curious to see how a simple intervention such as physical therapy has a profound effects on recovery rates and mortality rates. I utilized a total of 11 databases. All articles fell within the years 2016 to 2021, and the keywords are listed as seen. In the early versus delayed mobilization section, the first study done by Tariq et al. Was a quantitative single-blind randomized control study utilizing 174 postoperative CABG patients. He found that early mobilization significantly prevented pulmonary complications such as atelectasis and pneumonia, as well as marked improvements in dyspnea, oxygen saturations, and respiratory rate when compared to the control group. Also, he found that there was a reduction in the length of ICU stay. Qui et al. Did another quantitative randomized controlled clinical two-arms trial that had a total of 178 patients, 89 split equally into the experimental and control group. And he found that there was a significant reduction in pulmonary complications and infection, as well as a 46.1% increase in early discharge incidence amongst the experimental group. However, 90-day mortality rates remained the same amongst both groups. Early mobilization section, we had a qualitative study done by Das et al., which had 100 patients divided equally into the experimental and control group. It was found that the experimental group had a significant decrease in ICU length of stay, significant reduction in total length of stay, reduction in dizziness and lethargy, a decreased incidence of pulmonary complications, and a reduction in post-discharge deconditioning. In the outcome on mortality section, it was found that a qualitative systematic review done by Okada et al. Included 11 studies, 1,322 patients total, 662 assigned to the early mobilization experimental group. It shows that the experimental group had a significant reduction in ICU length of stay as well as total overall length of stay. However, there was no difference between both groups for in-hospital mortality. Another study done by Tipping et al. Was a systematic review, including 14 studies, a total of 1,753 CABG patients. It was determined that the early mobilization protocols had no impact on short and long-term mortality rates. However, it did show that the intervention group had resulted in greater functional ability and strength at the time of ICU discharge, as well as the increased probability of ambulation without assistance at the time of discharge. When implementing change, such as the early mobilization protocols, a culture change must ensue. A team of nurses, rehabilitative personnel, intensivists, etc., must be gathered to determine the best protocol with the best goals, as well as identify the established roles amongst each individual. Barriers to implementing this type of protocol would be perceived patient barriers such as excessive sedation, intubation, cognitive impairment, medical instability, as well as the need for more research, such as a standardized early mobilization program. Other perceived institutional barriers include lack of equipment and the requirement of orders, and perceived provider barriers include safety concerns, inadequate training, limited staff